Okay, well, welcome all of you to this week's Crisis Jam. I'm David Covington. I'm with RI International, and I'll be your host today. And we're thrilled to have today's featured presentation really give us a little bit of a history of the foundational work that led to us understanding the effectiveness and strengthening the consistency and quality of the network of crisis call centers nationwide that support the Lifeline and will support 988. And we were just talking here in the last hour about, if I remember right, as Dr. Maddie Gould's work was getting started, the common view, even among suicide prevention advocates, was that crisis call centers were not a strong investment of limited and precious funding. And there were a lot of myths about who would actually call a crisis call center, whether people who were quote unquote seriously intent on suicide would ring someone for help. And we didn't have data or research or studies that would contradict those myths that were out there. And Dr. Brian Mashara and John Califat and Maddie Gould all began doing what has been just some foundational work for 1-800-SUICIDE and then the Lifeline, and now laying the groundwork for 988. So we'll look forward to that discussion coming up in just a moment. Karen, let's go to the next slide. As we think through the pipeline of content for 2022, certainly we welcome your feedback. We've got a little bit of a hold here at 10 states representing Medicaid authorities. We have all 50 states related to offices of behavioral health. Our newsletter participation continues to grow. We're close to breaching 2,000 and are routinely breaking 300 now on a week-to-week basis of people who are actively engaged. But we do want to continue to grow that audience. And one of the things that we've been reflecting on is the type of strong financial content that would interest our Medicaid leaders, and also our Medicaid leaders could help bring some of that those featured presentations. We had more of that content back in the spring than we've had in recent weeks. So again, welcome your feedback on that. Just talking with Brian Hepburn and John Palmieri with Samhsa and NASBID about key ideas that we're looking for content and featured speakers getting into 2022. Medicaid and financing would certainly be one of those. Operational readiness at call centers, coordination with 911. States, we'll get into that state map and the state cards that we have for states that have already passed legislation, but looking for updates from some of those states, as well as more. We want to do more on the workforce, and Brian Hepburn will make some comments on that as we go forward. Next slide, Karen. You can continue to see last week's video if you missed us. You can see that material, the video itself, the transcript, all on talk.crisisnow.com, as well as the Zoom link. And again, please feel free to share that. Or if you don't have it in your calendar, you can just go to that website and click it. It'll bring you right into this learning community. Next slide. Dr. Richard Mckeon shared this quote from a presentation President Biden gave just last week. And it's a really emotionally resonant and powerful quote referencing the veterans who die of suicide, not in a far off place, but right here at home. And President Biden says there are daughters, our sons, our parents, spouses, siblings, beloved friends, and battle buddies. Each of these precious lives leaves behind loved ones who feel their absence every single day, like a black hole in the middle of their chest. So a great amount of feeling and commitment from the administration. We've seen this from both parties over the course of the last several years, but to hear the President of the United States talking about in the context of crisis call centers, he talks about Maddie, he talks about follow-up. In his most recent speech announcing a new military and veteran suicide prevention strategy. And we'll look to Dr. Mckeon to make some comments about that as we get further into the meeting. But with that, let's launch our featured presentation for today. And well, actually, we're going to take a little bit of a slight right turn. Sorry about that. We've moved the crisis talk up front today because we only have Dr. Pierluigi Mancini at the beginning of today's call. So Stephanie, you did an interview with Dr. Mancini. I've had the pleasure to have a friendship and work alongside Dr. Mancini for over 20 years now, when he was first launching a culturally and linguistically focused substance use treatment organization just outside of downtown Atlanta, focused on Central and South American individuals who come to the United States. And thrilled, Stephanie, that you had an opportunity to highlight some of the work that Dr. Mancini is doing.
Yeah, so he and I spoke about 988 and improving language and cultural competency. And Dr. Mancini, if you're on the call, one thing that really stood out to me is what can happen, and even the nuances in terms of having an interpreter who doesn't have clinical training, and it becomes a bit like the game telephone. Dr. Mancini, if you're on the call, if you could talk a little bit about the pitfalls of having just anybody interpret, whether that's family members, whether that's using professional services that don't have clinical training, or just pulling somebody in from your agency that speaks the language the client speaks, but doesn't also have clinical training.
Thank you, Stephanie. And hello, everybody. It's a pleasure to be here. David, thank you once again for inviting me to continue to work on this mission that every day grows more and more urgent and more important. Stephanie did an amazing job with this article. I hope you all have a copy of it and are able to read it. But what we wanted to highlight in the article is the importance of making sure that whoever you're taking care of is able to understand. And by understand, people need to be able to hear what you say, but also comprehend what it is that you're trying to say. So when we use a non-trained interpreter, and that has so many levels that we really have to be careful, because even interpreters that are trained may not have the behavioral health language. So what ends up happening is that they give the clinician their best guess, which is never good, because they just haven't had the training in the language we speak in behavioral health. And of course, if you use someone from IT in your clinic because they speak English or Korean or whatever it is, that is very inappropriate, because that person knows about their field. They're not the right person to interpret for you in a clinical setting. And of course, using children is just unethical. It's illegal to ask people to bring their own interpreters to your clinic if you receive any type of federal funding. So the horror stories that can happen is, for example, one that goes around, and these are true stories, and this was a medication management. The bottle said once a day, ONCE. But that's the same spelling of the number 11 in Spanish, once. So the individual took 11 pills instead of once a day. And so you can see the life and death situations that can happen by someone who's not trained interpreting for us.
Could you talk a little bit about, when we talked about cultural competency, sometimes ethnic groups and racial groups are all smushed together, and if you speak the language thereby, every culture within South America or Central America. And so can you talk a little bit about how it's not a stagnant thing, it's a continued education to understand your clients?
Correct. So, and this actually has a couple of levels, Stephanie. Getting to know where the individual comes from is extremely important, because not only do we have 22 or 26 different countries, depending what map or what designation you're looking at, within those countries, there are language and culture differences. So, assuming someone, oh, you're from Colombia, so you must be able to understand what this is and what that is. Not necessarily. I may be from a part of Colombia where I'm not familiar with that cultural practice in another part of Colombia. But also, this is a key point, because when talking to any kind of level, it could be a federal representative, a state representative, a private organization, we need to stop bundling all immigrants under one roof. Mm-hmm. There are tremendous differences, not only on how people come to the United States, but the ability for those individuals to have some type of coverage, some type of health insurance or social service availability. So often what I see is that whenever we speak about language access, yes, it immediately brings up the fact that if you have a linguistic barrier, except for deaf and hard of hearing, when you have a verbal language barrier, you're talking about immigrants. And unfortunately, we live in a politicized environment where people just want to say, oh no, we can't serve immigrants because, you know, they have immigration problems. Well, the immigrants that have immigration problems is a very small number compared to all the immigrants in the United States that have linguistic barriers. So we need to stop bundling everyone and look at every person individually and see what it is that they need, their linguistic and their coverage.
Thanks so much, Dr. Mancini, for joining us. Thanks, Stephanie, for continuing this great work. And again, if you didn't see Dr. Mancini's featured presentation a few weeks ago, that's available on the website. And it also brings to mind Steve Hammerdinger's presentation as well, related to deaf and hard of hearing services. So we'll keep prioritizing this work, Dr. Mancini, as we go forward. And let's now pivot to the featured presentation.
Thank you, everybody.
Thank you, Dr. Mancini. We're thrilled to have Dr. Madelyn Gould with us, who has done such amazing work over the last 20 years to put us on the right footing for now moving in 988 forward. Dr. Gould, welcome. And
thank you.
Please share with the group the effectiveness work that you've done in multiple studies funded by Samhsa now.
Okay, thanks, David. And thanks so much for inviting me. Today, I'll be presenting, as David just said, the empirical research on the effectiveness of the National Suicide Prevention Lifeline. And David already mentioned that much of this work bolstered the rationale for the establishment of 988 as the new 3-digit dialing code. Next slide, thanks. Okay. Next slide, we're good, okay. So national crisis lines were first highlighted in 2012. The National Strategy for Suicide Prevention that was developed that year. And they've continued, crisis lines have continued their prominent position in the 2021 Surgeon General's call to action to implement the National Strategy for Suicide Prevention. Yet in 2001, when the first national strategy was published, suicide crisis lines were noticeably absent. And at the time of the 2001 national strategy, the evidence base for crisis lines effectiveness was considered insufficient to include them in the strategy. The major milestone in the advance of crisis lines in the US was the funding of a national network of local certified call centers, funding by Samhsa, and that occurred in 2001. And so the rest of the slides, I'll be presenting the empirical evidence on the effectiveness of crisis lines in the US that emerged after the 2001 national strategy. Next slide, thanks. Okay. So the evaluation of the national network of crisis lines, as I said, has been ongoing since the network's inception in 2001. And results from the evaluations have been used by Samhsa and the Lifeline to shape best practice standards across the network. And new practices in turn led to additional evaluation studies. So what we've now come to call an iterative process is really unique and considered to be a gold standard in data-driven decision-making. Next slide. I won't be going into any details about the individual studies. So instead, I'll be presenting major findings. Prior to the Lifeline evaluations, there was the pervasive impression that callers to crisis lines were not seriously suicidal individuals. David mentioned that. The evaluations dispelled what was essentially a myth by demonstrating that seriously suicidal individuals reach out to telephone crisis services. We saw that about 8% of callers were actually in the midst of an attempt. 58% had made of the suicidal callers, 58% had made a prior attempt. So clearly, seriously suicidal individuals reach out to telephone crisis services. Our earliest evaluations also demonstrated that callers' suicide risk was significantly reduced from the beginning to the end of the call. And another major finding was that counselors at Lifeline centers were more likely than counselors at non-Lifeline centers to inquire about current suicidal ideation, recent ideation, and past attempts, and that callers were more likely to experience reduced distress. And as I mentioned, I'm not going into all the details because not only would I be taking all of this hour, I'd be probably taking over a couple of days. So I really am highlighting the major findings from the evaluations. Next slide. Determining whether a caller is at imminent risk of engaging in suicidal behavior and in need of emergency intervention is one of the most significant judgments that a Lifeline Crisis Center counselor has to make. And clearly, this is a judgment that frontline clinicians and first responders need to make as well. The Lifeline's imminent risk policy provides a formulation of imminent risk, evaluation of whether a caller is at imminent risk. And this imminent risk policy is based on the core concepts of the interpersonal psychological theory of suicide that was developed by Thomas Joyner. For want of time, I'm not going into the components that go into the IPTS theory and into the imminent risk policy, because the purpose of our evaluation was not to assess the contribution of these IPTS-based components of risk to the individual's imminent risk status. Rather, the main goal of our evaluation was to describe the types of interventions that are implemented with Lifeline callers whom counselors consider to be at imminent suicide risk. At the time that we did these evaluations, people didn't know even, to what extent did callers who counselors thought to be at imminent risk, were emergency services sent for all of them, what was going on? And what we found was that crisis counselors were and continue to be able to secure the caller's collaboration on an intervention on over 75% of imminent risk calls. And that on about 19% of imminent risk calls, the counselor sent emergency services, the police or sheriff or EMS, with the collaboration of the callers. And there was another quarter of imminent risk calls where the counselors did have to send emergency services without the caller's collaboration. Next slide. What we also found was, we identified, what were the collaborative interventions that didn't involve emergency services? And those collaborative interventions included getting rid of means, involving, what's called a third party. I think most people are familiar with what that means, but it means someone in the caller's social network, a family member, a friend, but another person, a third party, to get involved in ensuring the safety of the caller. That the crisis counselors could collaborate on developing a safety plan with imminent risk callers. And also the interventions included agreeing for the caller to agree to receive follow-up from the crisis center. We did another evaluation that focused specifically on third-party callers because we recognize that there are, unfortunately, a number of suicidal people who won't seek any help for themselves. They won't see a mental health professional, or call the Lifeline, but their parents, spouses, friends, are still very worried about them. And that the Lifeline, promotes its services to folks who are really calling on behalf and worried about, someone else. So this next evaluation focused on what interventions were occurring with third-party callers when they were worried about, someone else who the counselors then deemed to be at imminent risk. And what we found is that counselors provide a range of interventions which can supplement and at times, replace calling 911. What we also found with regard to keeping callers safe is, and David, mentioned this as well with regard to President Biden, mentioning about follow-up calls. We found that follow-up calls reduce suicidal individuals' perceived risk of future suicidal behavior. Next slide. To increase access to crisis services, Lifeline service format has evolved to include not only telephone crisis interventions, but also chat crisis interventions. And the Lifeline crisis chat, LCC, that's what that stands for, network, serves all ages. And it's grown extensively since its formal establishment in 2013, answering over 200,000 chats in 2020. Clearly, there are many more calls that are, answered in terms of the capacity of the network, and I'll be getting into that in a little bit as well. Next slide. Oh, I'm sorry, I tricked you, Karen. Could you go back, because I want to actually give you some findings. With regard to the findings from the chat, I just described in very brief terms what, the number of chats that, and this paper was published this summer, 2021, about 84% of LCC chatters endorsed either current or recent suicidal ideation on a pre-chat survey, which is markedly higher than the estimated 23% of Lifeline callers who were suicidal on the day of, the day of or the day before their calls. So it's really striking that there's just a much higher proportion of chatters who are suicidal compared to callers. And I'm just going to jump straight to outcomes, although, again, each one of these slides could be 20 slides in terms of giving you details. What we did find is that 2/3 of the chatters reported that the chat was helpful, and that we found that they were significantly and substantially less distressed as assessed at the beginning of the chat and then at the end. So we had 2 assessment periods. And moreover, about half reported being less suicidal at the end of the chat. I'll just quickly say that in the paper, we give many more details in terms of the implications of that half, because people have said, well, that leaves half who didn't report that they were less suicidal. And, when you start to look at the statistics for even, established interventions when they're available, and for the most part, they're not available, that the idea of having a crisis chat, a one-time crisis chat is not curing the person, but it is clearly, able to collaborate, the councils are able to collaborate with the chatters so that 50% of them will report being less suicidal at the end of the chat. Next slide. So I want to just give you a summary of, the Lifeline evaluations and what I have just said, and that number one, individuals at risk of suicide do utilize suicide hotlines. Callers experience reductions in their crisis and suicidal states over the course of the crisis call. Crisis counselors can collaborate with callers to de-escalate imminent suicide risk without the use of 911 or an emergency department, although they also do use 911 or an emergency service. So as I said, but it's not the majority of imminent risk calls that involve emergency intervention. Callers may experience continued or recurrent suicidal thoughts in the weeks following their crisis call. That's something I didn't specifically talk about because in terms of follow-up findings, that would take too long for the amount of time I have. So our earliest findings did indicate a need for follow-up and continuity of care. And that highlights that iterative process in that earlier slide, because instead of taking that finding as, clearly it was a troubling finding, but rather than just saying, oh, that's too bad, Samhsa and the Lifeline then realized, well, there is need for follow-up. So our very first evaluation actually laid the groundwork for follow-up, and then a subsequent evaluations of follow-up and showed that follow-up was effective. And that's why I have it as the last slide. Follow-up calls are important suicide prevention tools and should be really considered essential to any crisis service. Next slide. Crisis chat, so these are a couple of more summaries. Crisis chat services are utilized. I didn't mention this in an earlier slide, but our findings and papers show, even though the service is offered to the general population, it is utilized by a younger and higher risk population compared to those folks who call telephone hotlines, and they're important adjuncts to telephone hotlines. I think we all know that. And then Lifeline centers have been shown to be more effective than centers outside the network. Next slide. So again, emphasizing these iterative, the iterative process and the relationship between the evaluation and program and policy, that there are key challenges that we identified in our evaluations that have implications for the implementation of 911, and that there is still room, as everyone on this crisis jam knows, there's still room for improvement in communication between Lifeline crisis centers, 911, EDs, and other crisis and emergency services. Mobile crisis teams and stabilization facilities are not universally available at this time as resources for Lifeline crisis centers. And that chatters and texters, although I haven't gone into detail about texters, are more likely to be suicidal than callers. And Lifeline services need to increase capacity to meet their needs. This is not anything new. Folks on this jam know that as well. And next slide. So I just wanted to take the liberty of, for those of you who are interested in evaluation, at least the questions that immediately have come to mind from, my evaluation team is that, going forward, there are questions about imminent risk, callers, chatters, texters, and these questions, that I'm sure will be the focus of future evaluations, or I hope will be the focus of future evaluations, are how are imminent risk calls, chats, text resolved, including to what extent is imminent risk reduced during the course of the crisis intervention without needing additional services. We've already done some work as I presented, but there's more to be done. How often are 911 or police called by Lifeline crisis centers? How often are mobile crisis teams and stabilization units used? We don't have that information right now. Next question would be, to what extent is information shared between Lifeline crisis centers, 911, EDs, and other crisis and emergency services? What outcomes emerge after different types of dispatch and information sharing? And do dispatch and outcomes vary for different ethnic, racial, and gender groups. And as Dr. Mancini so sort of brilliantly highlighted, you can't bundle all immigrants into one group, and you can't bundle all of US population into one group, so that we do need to see how things vary by groups. And next slide. I have provided the, a number of citations that will provide, many more details than I can present today. And the Lifeline has been very generous in making at least all of, the papers that we have been involved in, writing based on our very, very close collaboration with Lifeline and Samhsa, that they're all open access. And so you can readily, access them. Okay, so thank you. Hopefully I kept to, did I? Oh, gee, I'm sorry. Did I go too
Maddie,
long?
you did great. And look, it's hard to capture how much this iterative circle of impact you've talked about in the slides has played out. But let's get some quick comments. Dr. John Draper, are you with us to make a reflection on Maddie's presentation?
I am. Thanks, David. All those questions you're asking, Maddie, at the end are questions that hopefully you'll be able to help us answer over the years, because delightfully, you are going to be contracted with us to be evaluating this work on an ongoing basis in the coming years. I did want to note, though, David and Maddie, when I was in graduate school in counseling psychology, they always talked about the value of bringing research to practice to improve psychotherapy and mental health care. But that was back in school, where the University Counseling Center was right up there next to all the researchers and professors who were doing the work. But in the real world, they're pretty siloed. The mental health practitioners in the communities and the academic researchers in academia. So when Samhsa began funding this network of crisis lines in 2001, they took this extraordinary step of baking into the grant the evaluation that had to be central to determining whether or not what they're paying for works. And that has changed everything. My introduction to Maddie was back in 2002 when she and her colleague, the late, great Dr. John Califat, came to our crisis center in New York City to be one of the 8 that they would evaluate in this first groundbreaking study. And when those findings first came out in 2005, we were just inheriting the grant administration at that point. And they were like a beacon to us, a gift that said, well, here's what you should be doing and could be doing better, and here's what you're doing right. And we handed those over to our crisis centers, and it's made all the difference in the world. In fact, not just the difference in the world for our crisis centers in the United States, but literally in the world. Internationally, the impact of these findings have been felt in crisis center services everywhere. I'd say, aside from the evaluations themselves, there's 2 things I think that are really important to note. But one is I think it's made such a big deal is, first, the involvement of Standards Training and Practices Committee, where we could build consensus and translate those findings into standards and practices that could be pushed out in the network, and then evaluate the impact of those. This is the iterative process that you're talking about, Maddie. And once we found out what still didn't work and still could be better, then we could go back, change those standards and practices, push them back out into the network, and then evaluate those. And that's what you've been doing so expertly over the years. That's been crucial, that Standards Training and Practices Committee of the Lifeline. But secondly, and probably most importantly, Maddie, you'll probably be the first to say, is that the most important thing has been the participation of our crisis centers in the network. Nearly 1/3 of them have been engaged in this. And when I was saying that you got to have researchers and practitioners close to each other so they understand the value of what the researchers are learning, that's exactly what has happened with our network. And it's really a tribute to our network of crisis centers, a number of them who are on this call, who can say, yeah, Maddie changed our work. And frankly, they changed Maddie's work too. Helped to make her, I think, one of probably the top researcher in the world related to hotlines. So Maddie, it has just been such a pleasure for working alongside you since 2002, and looking forward to our continuing work together.
Thank you.
Great comments, John. And we do have a crisis trivia hot seat coming up later in the show that will build directly off your comments, John. Richard, quick reflection on Maddie's impact and John's comments.
Yeah, absolutely. Well, first off, it has been an honor and a privilege to work with Maddie very closely on the hotline evaluations ever since I joined Samhsa in 2003. And I also want to echo John's comments really about the courage of the crisis call centers who have participated in these evaluations. They have really opened up their practices in a way that's pretty unique in the mental health, field. Including, things like, some of the studies, not any of them currently, involved live monitoring of calls. So it was really extraordinary the way they opened themselves up. And then without really any financial incentives coming from the federal government or elsewhere, but because of their desire to do better, they incorporated the practices and the learnings that came from the evaluations. Just two quick additional points. One is the importance of Maddie's studies on imminent risk. It is, in my judgment, absolutely stunning the absence of empirical literature and information about the life and death situations that crisis call centers, but also others and mental health centers, have to make every single day. And Maddie has made a major contribution to that with her studies. There's very, very little else that is out there. And then again, about the importance of follow-up, the fact that it is perceived as life-saving by the people who receive, the follow-up calls. Since Maddie's work, additional data from the SafeVet and ED Safe studies for use of follow-up calls after emergency department discharge have also shown this. And it's a reason why right now with 988, we have a unique opportunity to build follow-up, to institutionalize follow-up, and to get resources for follow-up as a part of the system. We've been building toward this point for a dozen years or more. Now is the opportunity to make it real, guided by the evaluation that Maddie has done, as well as some of the work coming out of NIMH and VA.
Terrific, Richard. I just reflecting, we had about 50 years of crisis call center work without a real professional orientation. And Richard, your leadership, John's partnership in this, and Maddie, your work over the last 20 years has developed something, as John said, which has impacted global practice. So terrific. And Maddie, you're going to stay on, and yes, we'll look for another comment as we get into the. Well, let's go to John Palmieri for the Samhsa update as we bring all this 2001, 2005, all the way forward to 2022 and 988. John, where are we at?
Thanks, David, and happy to be here as usual. I wanted to take a couple of minutes because I know that there's been obviously some movement in our staffing within Samhsa, and also I think some questions and confusion about where the 988 team sits and what is the membership of the 988 team. So I thought I would just take a minute to run down the list of all the folks within Samhsa who are working hard on the 988 behavioral health crisis team. And I'm thinking that maybe next week and weeks thereafter, we'll mix up the slide that you have there and have the team has been working on a very nice slide that has our faces and can attach names to faces and whatnot. So maybe we'll provide an update for that next week. But one of the key things that I wanted to highlight is that the team is now sitting within the Office of the Assistant Secretary, which is really critical and a huge opportunity for us. It's something that our Assistant Secretary, Dr. Miriam Delphin-Rittman, really felt strongly about wanting to have a direct connection to activities related to 988 in crisis space. And it also presents us with some tremendous opportunities for more visibility and more access to potentially to resources that can help support our activities moving forward. So she, along with the Chief of Staff, Sonia Chesson, are our executive sponsors for the team, and we're meeting with them weekly, often multiple times a week, to brief them on activities and seeking their support around key decision-making. I'm currently sitting in the role as the acting director of the 988 and crisis team, and also am the chief clinical officer and crisis systems lead. Eitan Raskas, who's usually on this call, is the deputy director of the team. Richard Mckeon, who you all know extremely well, is our senior 988 expert and the chief of the suicide prevention branch. His position still sits within the Center for Mental Health Services, but obviously is closely tied to the activities of the team in the Office of the Assistant Secretary. And James Wright, who many of you know, and is also usually on the call, is the chief of Crisis Center Operations and works closely with Richard and John Draper and folks at Vibrant on Lifeline operations. Kate Galatis, who's our chief 988 Communications and Engagement Officer, has been on this call previously and maybe on the call today, I'm not sure, but she's on detail from the CDC and has done a tremendous amount of work in a short amount of time on planning for communications and messaging. And Becky Zornick, who's our 988 project manager and policy advisor, has been a key member of the team for the past several months as well. So again, we'll attach some faces to names so that you can kind of have a visualization of the team members, and we're continuing to evolve moving forward. But I just thought it was a good opportunity to just kind of level set to understand sort of who's on the team, where we sit, and who's doing what kind of moving forward. And then the only other thing that I would add before moving back to Richard is just to flag for the group here that we are still very much focused on the operational readiness piece of 988 implementation and looking both at technical assistance and partnerships that can promote technical assistance and guidance to the field, including to states and to contact centers with respect to readiness for 988 implementation. And we're also actively looking at some potential mechanisms to provide funding to support and accelerate readiness at the state level. And hopefully we'll have more information about those activities in the near future. And I'm going to pass it off to Richard.
Thank you, John. I'll just mention two things quickly. One is that a reminder that it is this month that the FCC commissioners will be voting on texting to 988. Their proposal is already public and on their website. That will be voted on. We certainly anticipate that it is going to pass. We know it's but of course it won't be finalized until they actually vote. It's a major priority of the acting chairwoman who has been nominated by the president to be the permanent chair of the FCC. And she has spoken on a number of occasions around her view that texting is a critical aspect of 988 moving forward. And then the other thing, David provided the quote from President Biden. That's in the dedication or the opening to the new veterans and military strategy for suicide prevention. And if you have not had a chance to take a look at it, I'd urge you to do that. It describes 988 as a pivotal point for both access to suicide prevention and crisis services for Americans across the country, as well as the link to follow-up care. And there's also very important language where it calls for processes to be set up to look at how to embed effective suicide prevention practices and follow-up in emergency rooms, emergency transport, and urgent care centers. So there's a lot of really important implications, even outside the VA system and the Department of Defense system, with implications for the entire country. So I'll stop there.
Wow, Richard, and thank you, John, for that update. Richard, we've talked at length about chasing a 911 system that is exceptionally mature now, over 50 years old, and yet the FCC, if they vote to include texting 988, could jump past 911, as 911 is just beginning to roll out next generation services, including text, and we could have that much faster. That's a really exciting development and more burden for all of us to think through. So terrific update. Let's go to Dr. Brian Sims to give us an update from Nashville.
Thank you all.
And next slide, Karen. Yeah.
Great. Thank you all, first of all. And I would like to just say briefly, on the eve of the acknowledgement of Veterans Day, and you've heard already many speak on this. On behalf of NASPID, we just would like to express our deepest gratitude and honor to all those who have served or have served in the past or lost their lives in the service of the country. We are proud to continue our support of all the veterans through our collaborative efforts, both working with the states as well as through Samhsa, in order to address the veterans' needs. And we do this through advocacy, through technical assistance, and collaborative relationships. Now, much of the work NASPID has been doing over the years has been in support of the many ongoing efforts on the part of the states and territories, but has as well been in collaboration with the tremendous supportive measures through Samhsa. Now, we've developed over a year such groups as the NASPID President's Task Force on Returning Veterans, which was established to address issues related to provision of mental health services to veterans returning home, as well as a housing advocacy group that has been tasked with helping veterans to find resources and housing. So much of the recent attention that we've all seen, both in the past and leading up through COVID, has been the focus, as you've heard earlier, on the high incidence of suicide amongst veterans. And NASPID has been committed to working with Samhsa and with other entities to try to attempt to reduce these numbers through active identification, through early intervention, as well as supportive care. So as a veteran myself, I take tremendous pride in working with NASPID in these efforts. And again, I thank all those and thank all veterans and give honor to all those who have served. And I would also like to acknowledge, before I pass it back to Brian, NASPID's continued focus on our DEI issues, which involving equity, inclusion, as well as access to care. Now, the addressing of these issues with the states has been an integral part of the cross-cutting issues that Samhsa has already highlighted, and we're encouraged by the many efforts that we've seen through our collaboration with the states in attempting to address this very critical topic area. So at this point, I'll thank you all, and I'll turn it over to Dr. Hepburn.
Thank you, Dr. Sims. And just real quickly, I wanted to mention that as we do our state calls, one of the things that comes up repeatedly is the issue of workforce. And over the next few weeks, next few months, we'll be talking increasingly about workforce. But I just wanted to bring this to your attention. It seems like workforce issues are everywhere, but they are particularly in the area of behavioral health, and particularly in inpatient settings and community residential settings. So we'll be talking more about that. Next slide, please. So I wanted to bring your attention to the papers that we have done over the years. We have over 50 papers, as you can see here. I wanted to let you know that we had made a mistake before. We had these icons, but we didn't have all the papers. We just had the umbrella papers, as we call them. Now we have all the papers from 2017, 18, 19, 20, and 21. And I wanted to particularly bring your attention to the paper by Dr. Gould that was done in the 21 paper. So if you click on that icon for Ready to Respond, Mental Health Beyond Crisis and COVID-19, you can look up the paper that Dr. Gould did along with Allison Lake The title is Suicide Prevention and 988, Beyond Beds Before, During, and After COVID-19. It's an excellent paper, and we really appreciated the work of Dr. Gould and the presentation that she did at our annual meeting. However, I wanted to highlight again, there are 50 papers behind these icons. You can find almost anything you would need to find related to continuum of care in the community and crisis services. So thank you very much, and I'll pass it back to David.
So Brian, there are almost 200 papers between the 50 that NASHBT has created and the 130 that Stephanie has led through the interviews on Crisis Talk. It's a tremendous body of work. Let's go to the next slide, Karen. Last week in our Crisis Trivia Hot Seat, we talked about a paper that came out in 1966, which was the roadmap and basis for the emergency medical system we have today. I found a 30-year anniversary of that paper where people were talking about it defined their careers as they raised up 911 and EMS and hospital EDs that were immediately accessible. Really exciting as we look at similar opportunity in this crisis space. But let's go to today's Crisis Trivia Hot Seat. And we have Leanne Reinert with us. I believe, Leanne, you're the Deputy Director of Policy and Planning at the Illinois Department of Human Services Division of Mental Health. Leanne, are you with us? Leanne, welcome.
I'm here.
A long-standing Crisis Jam participant. So Dr. Maddie Gould's work, we talked about this iterative back and forth at John Draper and the professional orientation that he related that's had an impact worldwide. Between 2005 and 2010, Samhsa's Lifeline effectiveness evaluation studies that Maddie talked about directly led to the implementation of a set of standards and a specific policy that didn't previously exist. These important tools improved consistency and practice across the network. In fact, the standards, John referenced them being used worldwide. I was in the crisis call center in Belfast, Northern Ireland, and looked on the bulletin board, and I was like, oh my God, you're using the Lifeline. Okay, I almost said the answer. You're using these standards. Karen, let's see the question. It is, what were these key tools? A key standard and a key policy. Leanne, do you know those, or would you like to phone a friend? Lifeline, Maddie, and Samhsa are not your friends. They are your friends, but they can't help you since they definitely know the answer. Ask, or you can ask the audience, and that might capture a broad, but you've got some call center people out there. You could either name or you could ask the broader audience for help. Leanne, what's your preference? Or you may know
it. I don't know it. You know, my first friend that I was going to phone was John Draper, because earlier on you said, John, that leads into the crisis hot seat call. But if I can't phone John Draper,
so I'll give you
I would ask the audience.
Here's a clue, Leanne. John Draper and Richard Mckeon are both authors on the two publications that came out from this standard and this policy. So they know the answer, but they are our friends and not a phone a friend. So let's go to the audience. Audience, if you'll jump in, especially you call center folks, there's a key standard, a key policy on the Lifeline website. It shows there's a key link on the website that has 3 elements: the standards, policy, and reference to all that great follow-up work that Maddie referenced. So what are we seeing in the chat? Let's see, Leanne, what's coming up there? I see Suzanne Rabideau's helping imminent risk
policy.
Sandry Kramer. Sandry, tell us who you're with in the text chat, if you will. Sandry says imminent risk policy and suicide risk assessment standards. So she's with Dee Dee Hirsch. Dee Dee Hirsch operates what was the inaugural crisis call center in the United States, started in 1958, Leanne. So she's a great one. What's your answer, Leanne?
I like those, imminent risk policy and suicide risk assessment.
Sandry and Dee Dee Hirsch nailed this. Karen, let's see the next. First, the suicide risk assessment standards, which did build specifically on that interpersonal model of suicide that Maddie referenced. Those standards, there just wasn't a framework in that way prior to 2006. And Richard leaned into this policy quite a bit, and it is the helping callers at imminent risk. This collaboration, active engagement, and then active rescue when required, and the publications on both of those. Leanne nailed it today, thanks to great participation from our audience. Richard, any quick comments? And then I want to look to Maddie Gould as well for a quick comment on this.
No, I was very impressed by how many folks knew about the imminent risk policy. That's great.
And then Maddie, you were just making a quick comment when we were reviewing the slide earlier.
Yeah, that, you know, when the standards came out, the Lifeline was focusing on, you know, the suicide risk standards. And now if you go to the website, you'll see that the emphasis has shifted slightly to, you know, safety assessment standards. It's very, the components that you have on the slide are still part of that, but it's just a broader conceptualization of, you know, keeping the callers safe. I also wanted one shout out to all the centers who participated in the evaluations. It's usually part of my presentation, but I didn't, as it is, I went way too long. But these evaluations, as John and Richard said, could not have happened without a lot of hard work on their part and collaborating with us. So thank you.
Leanne, you know, stay on the line. Karen will be in touch with you with your list of prizes and other rewards that come from nailing this week's Crisis Trivia Hot Seat. Thank you. All right, next slide, Karen. That's great. Terrific. We saw all right answers. Suzanne, Sandri, and others were jumping in and nailed that one. So terrific. Let's get a quick comment from Sarah. Sarah, that infrastructure bill passed the House. Where are we at?
The Bipartisan Infrastructure Framework, also known as BIF, my least favorite acronym of the year, did pass the House, and that was originally coupled with the Human Infrastructure Package that's going through reconciliation, but that train has left. We are waiting on a Congressional Budget Office score for that reconciliation package. Some of the more moderate House members and more moderate Democrat Senate members would like to see the official CBO score for that bill. CBO is working as fast as they can, but it's a 2,000+ page bill. So we are expecting to see hopefully some preliminary information by early next week. And then the House would like to vote on that bill by next week when they're back in session. If that does end up happening timeline-wise, it's going to have to kick over to the Senate. They'll go through a vote-a-rama process, some amendments, edits, and then they would have to send the final bill back to the House for another vote before signing it into law. So still a little bit of a ways to go, a little bit more procedure, but they are hoping to wrap it up by Thanksgiving, although that is a bit of a tight deadline. We also are coming up to the continuing resolution date, where our continuing resolution keeping the government open and funded is set to run out at midnight on the 3rd into the 4th of December. So we'll have to see some action either with a full appropriations package, which is looking unlikely at this point, or another short-term continuing resolution through the through or up into the holidays in December. So we'll keep an eye on that. And also ongoing debt limit negotiation is coming back with a vengeance. So it's going to be a busy December on the Hill, but hopefully we'll see some progress, at least on the reconciliation piece in the next couple of weeks.
Terrific. Thank you, Sarah. And just for lack of time, AFSP will come to you definitely next week. Let's skip all the way to a quick comment if we have from Hannah or Steph related to the map. Any updates for this week, Hannah or Steph?
Hi, this is Steph Pasternak with NAMI. So no significant state legislation updates for this week. Just a reminder, though, that we are less than a week away now from our Reimagine event, which is our week of action, all about 988 that NAMI is hosting in partnership with 32 organizations, many of which are on this call. It's really an event for anyone that wants to use their voice to advocate for better crisis systems ahead of the launch of 988 in July 2022. And I'll just drop the registration link in the chat.
Thanks so much, Steph. And we did have a And Laura Evans is not with us. She's on PTO, but there was a special committee meeting in Kansas. Do we have any information on that?
I do not have an update on that now.
All right, so we'll look to maybe highlight this coming week. We've just got a quick minute left. We do have Kim Myers with the Utah Department of Mental Health and Substance Use that is working on a state stat card, and also we'll be brokering with some of the other states. We've already got Washington and Nevada, and we'll look to the other states in blue and light blue to have these state stat cards over the course of coming weeks. Let's look at the pipeline for today. And we've got Thanksgiving in 2 weeks and the end of the year holiday. So we will be off November 24th, December 22nd, and 29th. But Ron Bruno will be joining us next week, the dedicated mental health crisis response model with CIT International. Thanks all of you for joining, and Maddie Gould, our featured presenter. Thanks so much for being with us. We'll look for a crisis trivia that you can phone Samhsa or Vibrant next week. Richard, we'll put our heads to the grindstone and see if we can't get something that pulls you into the mix next week. Thanks everyone for joining.